has just recorded its first death linked to monkeypox, but there are many more questions and there are answers. I'm Barkha Dutt, you're with the Mojo Story. Our big focus today is going to be looking at a monkeypox, what we know, what we don't know. All of this happening, of course, as COVID hasn't gone away. But monkeypox is what has been declared as a global emergency by the World Health Organization. And 95% of cases, according to a new survey, have been transmitted via sexual activity, leading to a furious debate in medical circles over whether monkeypox should be classified as an STD or not. But the same survey has actually declined to do so. This survey, published in the New England Journal of Medicine, said that this was not a classic sexually transmitted infection. However, the World Health Organization has issued a warning or cautionary note of sorts for the gay community or gay and bisexual men who are sexually active with other men. There's a lot to unpack here. And we're joined by our newsmaker today, Dr. Soumya Swaminathan, the chief scientist of the World Health Organization. And as I said, monkeypox is unfolding even as COVID hasn't gone away, and the battle against AIDS globally seems to be faltering and fumbling just a bit. So a lot to ask. Dr. Swaminathan, thank you so much, ma'am. It's always a pleasure. Let me start by asking you, what we know so far, the big debate around monkeypox. And I should again underline that as far as we know, there have been only 4 recorded deaths outside of Africa. So even if you get monkeypox, it isn't something that, as far as we know, is going to be fatal, is going to lead to serious illness. But what do we know so far? What has led to the spread across 75 to 78 countries, ma'am?
Thank you, Barkha. As we see, the monkeypox outbreak is expanding and evolving every day. And the first thing I would say is that we're still learning about it. We do not have all the answers. And so one of the reasons why the Director General actually announced that this was a public health emergency of international concern was firstly because of the extraordinary spread, the apparently new mode of transmission affecting certain communities, and thirdly, the fact that we know very little about the epidemiology, the transmission, as well as how to manage and treat and prevent this infection. And so the public health emergency of international concern actually promotes international collaboration. It also energizes countries to invest more in looking for monkeypox, because clearly the underreporting is huge, and we don't even know what the real numbers could be globally because there's such limited testing going on. So I think it's a sort of a wake-up call for us, almost as though nature is reminding us that there are many more infections out there which normally circulate in the animal kingdom, and we don't know when, where, and how these viruses can jump and start this human-to-human transmission chain. So in a way, it's really telling us that we need to understand these infections much better. As of now, we have about over 20,000 cases reported to WHO. As I said, it's an underestimate, 5 deaths. And as the cases increase, unfortunately, we might start seeing more severe illnesses, hospitalizations, and deaths, because we know that while it's generally a benign disease in most people, it can cause a lot of discomfort. But there are, a small percentage. In Africa, roughly 1 to 10% of people have died due to monkeypox across various countries, across the different, over the last decade or so. So far, the death rate in this outbreak has been quite low, but that could change anytime if it starts spreading into the more vulnerable groups in the population.
So basically, you're saying that because the testing is so limited, we actually can't draw any conclusions even about its severity. We have to hope that it remains this way, but we simply don't know. Let me just dive into a big debate that's taking place in medical circles. Now, the World Health Organization cautioned men who are sexually active with other men to restrict partners, to reconsider sex with new partners whose sexual history will not, is not known. It was reminiscent in a way of HIV when the world first started understanding HIV, and yet this has not been categorized as an STD or an STI, a sexually transmitted disease / infection. Why is that? Is that only to avoid the stigmatization of the LGBTQ community, or medically do you not see it, basis what we know so far, as a sexually transmitted infection?
It's the latter. So, in the sense that monkeypox is not a traditional sexually transmitted infection. In fact, there are some studies now showing that the virus DNA has been found in semen, in vaginal secretions. It's possible that it could also spread through the exchange of sexual during sexual activity. But the main mode of spread is the skin to skin contact and the face to face, because it is the vesicles that carry a lot of the virus. It's the rashes, the blisters that you have on the body, and therefore any close physical contact between two people can result in the spread of this virus. And of course, sexual activity is does involve very close physical contact, and so that seems to right now be the major mode of spread. But we have to remember the other modes: face to face, skin to skin. So it could be between a family member and a child. In fact, the two cases that in children reported in the US were both linked to an adult male who had monkeypox and was living in the same household. So household transmission can occur. And also, we know that the droplets, when we speak, if there are lesions in the mouth, etc., that virus can be expelled while speaking and coughing. And also that, the lesions that fall off on bed linen, for example, on bed sheets or on other household objects, those can get aerosolized into the air and potentially transmit. So there is a potential also for airborne transmission. So we need to understand more about that and how common it is. Right now, the outbreak is spreading largely between men. As you know, 98% of the reported cases have been among men who reportedly have sex with other men. But it's really the close physical contact here that is that's what's spreading.
I want to understand a little bit more about this face-to-face transmission, just also to avoid a kind of stigmatization and paranoia. The more we know, the better it is for people to not get paranoid. If you remember, with HIV patients in the early years, people would think shaking someone's hand or sitting with them at a table having a meal would transmit the virus, and of course that was not the case. When you talk about face-to-face or household transmission of parent to child, does it need kind of bodily fluid or open sores for someone who's infected? What do you exactly mean by monkeypox can transmit face to face and potentially thus can be airborne?
Yes, it's important to highlight that it is not the same as COVID or one of these commonly transmitted, common cold viruses where somebody coughs into your face and you get it. Monkeypox requires much more close physical contact. And as I said, the virus is present in the lesions. We still need to understand whether asymptomatic people can spread the infection or not. But most of the infection is occurring when people have these blisters. The fluid there is full of virus, and so most people also get blisters on the face and the mouth and the nose region. And when they speak or cough, or you're close to a person, then what happens is that, as you know, droplets come out of our mouths when we speak or shout or laugh or sing, and those droplets contain viruses all the time. This is how respiratory viruses spread. But in this case, it's because the blisters have the virus, and so it's usually from someone who has symptoms. So this is why it's easier to control than COVID, for example, where a lot of times asymptomatic people were spreading the infection. Here, if you have a rash, you've had fever, body ache, etc., and then you break out in a rash, and then it becomes vesicle, it looks, those are the signs that you need to isolate. And people who are around such a patient, if you wear masks, both the individual and the carers wear masks and wash your hands regularly. Basically, it is the exchange of body fluid. So every time you have to handle, of course, if it's a patient, whether it's a healthcare worker or a family member who's looking after them, hand washing, masking, and trying to maintain a distance um, will all help towards reducing the transmission. So I think these measures are much more effective here because of the fact that it's the symptoms and signs are very classical.
Of course, I mean, I was just thinking that we're returning to the age of the mask. The masks seem to be a perennial part of our lives. But I just want to sort of push a little bit more on understanding why it's not being classified as a sexually transmitted infection. One, of course, is the fact that children, there are some cases of children having got it, and you've explained at great length the science of it. But that 98% of those reporting monkeypox are men, reported to be sexually active with other men. Most people would look at that as a classic STD. And if you say it's not, just for people who are not from medicine, just for the layperson, if you had to explain why it's not, what would you say?
I think the most common sense explanation would be that if you classify it as an STD, then anybody who's not having sex with an infected individual will consider themselves not at risk. But we know that it has these other modes of transmission. In fact, that's the classical mode of transmission, is through physical contact. And in Africa, in fact, it usually spreads within families, and quite often children there are getting infected and spreading it to other children. So that's the classical. Now, this time it's different. This is the first time we're seeing an outbreak in a particular community with a particular risk factor, which is men having sex with other men. And so we really need to go understand this much better. Of course, we have to take the public health action now, but I think there's been a confluence of factors that has allowed this to happen. One is that most young people don't have immunity because smallpox vaccination was stopped in 1980. So those of us who have had smallpox vaccine have some degree of immunity. We don't know how much. And the second reason is, so there's a lot of susceptible people. The second reason, that the virus itself, has it changed? Has it adapted itself, to this kind of human to human transmission? So we're looking now at the genetic sequences to try and understand how the virus might have evolved. And the third is, of course, the behavior. And this kind of a situation where there are a lot of partners within a short period of time, and you're not really knowing whether somebody has symptoms or doesn't have symptoms, this gives an opportunity for the virus to move very quickly from person to person to person. Normally,
Yeah.
it wouldn't happen. So that is why I think we're seeing this. And that's why it's not only a sexually transmitted infection.
So the high risk group, or the highest risk group, is men having sex with other men. But of course, other people can get it as well, in all the ways that you've just explained it. You mentioned the smallpox vaccine, and I'm of the vintage where I received one, you received one. There's in fact a question from Himanshu Das asking exactly this of you, Dr. Swaminathan. So therefore, is getting the smallpox vaccine an answer? There are a couple of vaccines that are being reported in use, at least in the West. Should people now be talking about a vaccine for monkeypox? Are we going back to the days of the smallpox vaccine? What do we know so far about vaccines and monkeypox?
Again, a lot of research questions. And just to tell your viewers that the WHO is convening a research and development blueprint meeting tomorrow, exactly to lay out all of the questions around small vaccines for monkeypox, and also develop the core protocol so that all countries can start getting engaged in research, because there are lots of unknowns here. Now, the world, of course, developed smallpox vaccines. There was the old vaccine that we all received. Then there are second and third generation vaccines. And because this is an orthopox virus that's closely related, it is believed that the smallpox vaccine will have good protection against monkeypox. And that's what the lab data actually are telling us. This vaccine just generate antibodies which can neutralize the monkeypox virus in lab studies. There have been no clinical efficacy studies for monkeypox using these available vaccines. Now, what are the vaccines? There's a vaccine called the ACAM 2000. It's an older generation vaccine, and there's quite a large volume of that available globally in stockpiles. It is likely that that vaccine has a little higher rate of side effects, and there are better vaccines now for smallpox. There are two. The Bavarian Nordic vaccine, which is also called Jynneos in the US, and it's a MVA, it's a modified Vaccinia Ankara vaccine. And then there is the Japanese LC16 vaccine, about which there is less known, but there's also a stockpile of that. Now, we have to think about how best we use these vaccines in the current outbreak, because of the fact that, again, we have very limited supplies. There are only 16 million doses of the Bavarian Nordic vaccine. Most of it is lying as bulk. It has not been filled and finished. And a lot of it actually belongs to the US national stockpile, the defense stockpile. And therefore, the US has the first right on it. Of course, they have allowed Bavarian Nordic to sell it to other countries, So many countries are requesting for the vaccine. So what the WHO is saying now is, in any case, there's not enough vaccine to go around, and it's not a silver bullet. So we have to take the other measures, the preventive measures that we talked about, which can actually break that chain of transmission just now. There is a window of opportunity here for us to break this chain of transmission. If it spreads too wide globally, and and then it also has a risk of becoming um, uh, endemic in the animals in those countries where it's now spreading human to human, and then it just becomes difficult to eliminate, let alone eradicate. So a lot of work to be done still on the vaccines. They have a role to play for sure, but with limited doses, we have to see like who are the highest risk groups who should be getting the vaccine now.
Yeah. Well, I mean, I think the world is just, sort of recoiling from the thought of another global health emergency, but we're all acting as if COVID has gone. And you in the World Health Organization has been reminding us that we've got to be on the lookout for possible new waves. Uh, what is causing you concern? We've of course seen a kind of U graph in the mortality rate, and some reasons have been offered for it, including a lag in vaccination in certain parts of the world, the fact that people have got careless, the fact that there's a lot of travel and economic activity back. But is there anything else that's of concern? For example, the new Omicron subvariant. Why are you telling us to be prepared for new waves?
Well, the reason is that every time, there is a downward trend in the global cases, then we tend to think this is the last, it's over. Let's just get back to normal life now and forget about COVID. Unfortunately, we still have a lot of unvaccinated people in the world. A lot of them are on the African continent, but in other countries also, there have been people who haven't taken the vaccine either out of choice or because they haven't had access. Luckily, India has done very well in terms of vaccination coverage, including in the high risk populations. So we still have those vulnerable people out there. Secondly, the virus is really being able to adapt itself and become infectious. So it's able to overcome our immune responses. It's able to develop mutations that evade the existing immunity. So we've seen with BA4 and BA5, for example, that even people who had been infected with BA1 got reinfected again. And the third is that our immunity tends to wane, particularly the neutralizing antibodies that we have. 4 to 6 months seems to be the time in which it wanes enough for the new variant to be able to infect us again. So I think we see over the last few weeks increasing cases despite reduction in testing in most countries. We've seen a rising trend of cases and, unfortunately, increasing hospitalizations and deaths. And we had last week, I think, over 12,000 deaths being reported to the World Health Organization a day. So, we are not at low levels of deaths. And these are just the reported deaths. So this is the reason why we're saying that we need to be careful, because there's of course, a huge impetus now for R&D on better vaccines. There are lots of nasal vaccines under development, 12 of them in clinical trials. There are pan-coronavirus vaccines, which will then hopefully take care of all variants. We still need to figure out, whether people need additional boosters, yearly boosters, especially if they're in the elderly age group. There are questions that need to be answered. Until then, we need to take precautions. Simple things like keeping masks on when you're in crowded settings, particularly indoor, making sure that you test and isolate if you're positive so that you're not passing that infection on to other people, and making sure that the vaccination coverage is up to date.
Let me ask you about vaccines, because I know a lot of people in the audience would want to know. We have started what the government in our country calls precautionary doses, which is what we are calling the third dose, the booster. Now, what a lot of people would want to know, especially those who are elderly or who have elderly people at home, is this, till we know more, should this be an annual feature? Are we talking about three vaccines for the foreseeable future till science delivers us more vaccines? Or should we be taking a fourth vaccine, a fifth vaccine, till there's so much we still don't know about COVID?
No, this is a very good question, and we don't have a definitive answer. What we do know from the vaccine effectiveness studies that have been published is that a third dose is necessary. And that's why we recommend a third dose um, for everyone, but particularly for the vulnerable groups. Now, after a third dose, you have quite high levels of protection against severe disease, which is the outcome that we are most interested in.
No, but how long
So,
does that protection last?
yeah,
Sorry, I'm cutting you short. How long does that protection last? Do we know any more about that?
the protection seems to last for at least 6 to 8 months. Now, it does vary a little bit vaccine to vaccine as well. And this is why we need more data. Most of our data is coming from the mRNA vaccines from high income countries. So, we need more data on populations from India, for example, in different subgroups of people. Who are the people now getting hospitalized with COVID? I think if we could understand who are the people getting sick, what is the age profile, and when was the last dose of vaccine they took, then we can start beginning to piece the story together and say, okay, maybe people over 60 or 65 or 70 need a fourth dose or an annual dose. That's the way we'll have to build the evidence base and then take policy decisions.
But if your research shows that the vaccine protection lasts 6 to 8 months, then for most people in India, for example, who have been triple vaccinated or at least double vaccinated, 6 to 8 months is over. It's over. They're already in that phase where they possibly now need a third or a fourth vaccine. Third for sure, you've already said. But what about
Yes.
those for whom the third dose was 6 months ago or 8 months ago?
Well, one thing is a lot of people have had natural infection also, particularly with Omicron. So that also does boost your immunity. We know that people who've been fully vaccinated and then get infection, it boosts your immunity even more. So I think large proportion of people probably have a good immune response at this point. And the protection against severe disease lasts longer than the protection against infection. So it's possible that after 4 months, you'll get again a COVID. In fact, some people have got it even, within a couple of months of the last infection. But it doesn't make you very sick. And yes, it's a few days of discomfort and, taking rest and being at home and out of work. Those discomforts are there, those inconveniences. But majority of people will not end up in the hospital, except for that group. And that's why I keep coming back to the elderly and the immunocompromised. We need more data on that group so that we can take a decision on whether to give them annual or even more frequent. But at the moment, most people will not need an additional dose after the third dose because they're protected against severe disease for quite some time.
I mean, there are all the questions about long COVID that we're still researching. Even if you don't feel very sick while you have it, there are now neurological complications that people develop later and so on. So a lot to still learn. I have to finally, in the last few minutes, move though to another, what could be another global health challenge. I won't call it a crisis, and that's what's happening with the battle against AIDS or HIV. First, of course, you were honored for sort of your contribution to this space, and congratulations, ma'am. That's the picture there. So many congratulations. But in that moment of pride, was there a moment of concern? The data doesn't look good. The last 2 years with health systems focused on COVID have not had time for a number of sort of other issues. Tuberculosis, we've seen that in India, HIV, AIDS in a lot of other parts of the world. How bad is it? How concerned are you?
Well, I'm concerned, and so are most people attending this International AIDS conference in Montreal. And thank you for your wishes. And I was humbled that they recognized me for my work. But I think what we've seen from the UNAIDS report, which is labeled in danger, is the fact that we still are seeing 1.5 million infections a year. And during COVID, actually what suffered was the outreach work, the community-based work, and therefore the number of new cases that were not detected went up. That we're still seeing 650,000 deaths a year. And as you know, we have this 95, 95, 95 target, which is 95% of people living with HIV should know their status, 95% of them should be on antiretroviral treatment, and 95% of them virally suppressed. And the big theme of this conference, which the activists actually were very insistent about, is U equal to U. Undetectable is equal to untransmissible. So you need to have people living with HIV to have undetectable viral load, which means all people should be on ARVs. Now, that's not the case globally. And if you take children, for example, only 50% of children with HIV are on antiretrovirals. And we're still having mother-to-child transmission, despite all of the... So the thing is, the science is there. The science is getting better now. This new treatment or prevention for HIV, where you take one injection every 2 months. You don't have to take PrEP on a daily basis. There's a lot of progress being made on better treatments also. There's a dream that you could have a once in 6 months injection to treat you, instead of taking daily pills, and a lot of work on vaccines. But meanwhile, I think we need to do, and every country, including India, is look at our own data very carefully. HIV is mainly spreading among high-risk populations, and every country needs to understand their high-risk groups. I think an inclusive approach, which involves the communities, that is targeted to them, but the strategies, and India has done very well really in involving communities in the national HIV response, that needs to be further strengthened. There are new challenges people are facing, sex workers, for example, now with monkeypox, there's one more threat to their livelihoods again. So there are many social and economic issues that will need to be addressed. And HIV and TB are both diseases which a biomedical approach alone is not going to solve.
Yeah.
It needs societal involvement and a sort of an all-of-government approach to deal with it. This is the time to and then finally, I would say investment. Without additional financing for HIV and TB programs, we're not going to get to the point. We have the tools, we have better diagnostics, better drugs, but we need to reach people. And for that, you need also more financing.
Well, even in India, which has actually bucked the global trend in terms of those numbers, it's done, reasonably well in terms of the numbers. There have been protests in the last few days, with families actually sitting on protests saying they can't access drugs. The government says there are enough drugs. It's one company that hasn't been able to produce on target. But I think if COVID taught us anything, it's that you can't separate the questions of public health from, as you said, all the other societal issues. Dr. Swaminathan, thank you. You're in Canada attending that International AIDS conference where you were honored for your work. We let you go now. We've taken enough of your time, but so much to learn. And as you said, every day is another reminder to humanity, really, of the world is giving us a message, and I think we have to literally stand up and take notice. Thank you so much for talking to us, and I'm sure there'll be lots to ask you in a few weeks or months from now as we learn more. Take care and have a great day.
Thank you. Thank you very much, Barkha.
Thank you, ma'am. It's great to see you here. Thank you for watching our work. If you haven't subscribed yet, don't forget to click the bell icon and subscribe to Mojo Story and support independent, robust journalism.